So hello everyone, and welcome to our fifth seminar in our Research in Action series at Trinity College Dublin. My name is Luciana Lolich, and I'm the Research Impact Officer at the School of Nursing and Midwifery. This series explores how research can drive real-world impact in policy and practice. We are delighted today to welcome Professor Mary McCarron, Professor of Aging and Intellectual Disability at Trinity College Dublin, Director of the Trinity Centre for Aging and the Life Course in Intellectual Disability, and Executive Director of the National Intellectual Disability Memory Service. Professor Mary McCarron founded and leads IDS-TILDA, a landmark longitudinal study that has influenced healthcare practice and national policy, and she led the development of Ireland's first dedicated memory service for people with intellectual disabilities. She's also a strong advocate for public and patient involvement and plays a key role in the mentioned research nationally and internationally. Professor Mary McCarron will speak for about 40 minutes, and then we'll have some time for questions and answers at the end. Thank you for joining us today. Professor Mary McCarron, over to you.
Thank you very much, Luciana. I'm delighted to be with you today, and thank you for joining. So I'm going to talk a little bit about my experience and the experience of the team here in terms of building collaborative pathways between policy and practice. So why did we want to focus on aging in people with an intellectual disability at the start? Because this is the first time in history people ever lived to old age with an intellectual disability, and that's certainly something to be celebrated. But we now know that they're aging with complex health, social support concerns. And we really, I suppose, need to think how we're going to deliver care to this increasingly at-risk population. Historically, this population have been excluded from aging research, and there's a need for rights-based inclusive data. So this here is a map of the world, and all the dots you see in this map are longitudinal studies that happened all over the world. So in Ireland was launching TILDA, which is the general study on aging led by my colleague, Professor Roseanne Kenny. I was asking the question, how come no other country in the world ever included people with an intellectual disability in the general aging studies, despite the fact that we know that they're dying about 20 years earlier than the general population. And there is limited evidence on how we can address the avoidable mortality in this population because there's a dearth of longitudinal studies. So I'm really delighted to be able to say that we were able to launch and got great government support and support from the Health Research Board in Ireland to establish the first nationally representative longitudinal study on aging in people with intellectual disability, where we're able to compare their health and well-being to the general population. So this is really exciting. We have done 5 waves. We're now out in the field at this moment collecting wave 6 data. So that is 18 years of longitudinal data. And when we started this study at the beginning, people said people with intellectual disability wouldn't be able, the protocol would be too long, there would be all of the ethical and IRB approval issues. And I'm really pleased to say that we have had huge retention rates in the study over the lifetime of the study, with almost a 90% retention rates, which is really seldom seen in this type of work. We have a very comprehensive conceptual framework which really captures a lot of data on the social and physical determinants of health and well-being, looking at things like interpersonal relationships, social inclusion, self-determination, psychological well-being, physical well-being, and health and social care supports. And then we have a family caregiving arm to the study, where we interview families who are supporting the family member live at home, and we're able to understand what are the tipping effects for family caregivers. And then we're really interested in death and dying and mortality, and we have an end-of-life arm as well. So IDS-TILDA really has data now to evidence to monitor health policy for this population. And we really probably have the best data set on the aging of people with intellectual disability at a global level. So we have very comprehensive data on the health and well-being. And one of the most critical issues for people, if you're trying to influence policy, is that you have trusted data. And I think that's the first piece of advice, is that we have really strong trusted data that policymakers and government can rely on. It uniquely facilitates this data, the monitoring of key government policies and strategies that aim to support health and ageing for this population, and provides for evidence-based policy review and development. And these are some of the policies which we can influence, but we can also monitor targets set out in government policy. When we started IDS-TILDA, it was just the time when we were looking at the deinstitutionalisation of people with intellectual disability, and we now are able to look at intergenerational difference and really understand, how the deinstitutionalisation has really improved and impacted on health and well-being for this population. But from its very inception, we involved people with intellectual disability. Ever before I really understood what PPI even meant, we were doing PPI here as a team because it just made sense. And while we were using a protocol that was developed for TILDA for the general ageing studies, and we want to be able to compare in Ireland with how the general population are ageing, but we also want to be able to compare across the world. But we also felt it was really important that we got input from people with intellectual disability to ensure that the questions or there wasn't issues that were relevant to them that weren't included. So between each wave, we go back and we look with them and we work with people with intellectual disability on our PPI panel. People with intellectual disability are highly involved in the training of our field workers. They are the group that come in and we have to train people specifically to go out and administer the protocol and the questionnaires. And people with intellectual disability to the PPI panel, which is chaired by Dr. Maylene Yap, a lady with Down syndrome, chairs that panel. And this has been very critical and really good feedback from our field workers in terms of the importance and hearing the story from people with intellectual disability and getting their assessment. And then Maylene has been very involved in disseminating of result and then, of course, translating the findings. And I was very happy on behalf of the team to accept the HRB inaugural Impact Award back in 2019, and really, which is very much geared at delivering and driving policy change and really trying to transform the lives of people with intellectual disability as they age. And most recently, very happy on behalf of the team as well to accept the HRB HRCI Impact Award in 2024, which really recognised the involvement of people living with an intellectual disability in the research design, this was a project that we also worked with in the developing of post-diagnostic standard and standards of care, and worked very closely with the National Memory Clinic and a Vista Memory Service. So people with intellectual disability have very much shaped our research agenda and shaped how we transfer, make our story visible to various groups. So really moving on to that, this is really some of the strategies that we've used to try to influence health policy and behaviour. And firstly, it is trying to understand what groups we were trying to reach, and then how we would target different groups to understand the data. Because we wanted to influence policymakers, people responsible for the commissioning of service, people responsible for the delivery of service, NGOs, people who use the services, the experts, people with an intellectual disability themselves and their families. And of course, the academic and research community. Yes, we need to publish and we do publish. But really what I'm saying here is that each of these will require a different format. And that's really important. And it's really important for researchers, I think, to understand the policy window for opportunity and the policy life cycle and the push and pull factors for policymakers, because policymakers have a lot of demands. They're extremely busy. So presenting data and information in a way that's accessible and meaningful to them. But it's really important to understand that policy window, because I always say once the policy is written, the train has left the station, and if you're not in, there's little chance perhaps of the desired change happening. And then, of course, you need to build agility into the system and be prepared to pivot. And I just want to give one example here in relation to how the IDS-TILDA data was used during the COVID pandemic. So when the pandemic happened, we had really good data on people with intellectual disability who are going to be at risk of getting COVID and who are going to have poor outcomes should they get COVID. And we were able to use that data, working with Dr. Alison Hartnett, who's the Chief Executive of the National Federation of Voluntary Service Providers, work with government bodies and feed in that data. So it really did help people with intellectual disability to be prioritised, and particularly people with Down syndrome, in terms of the vaccination protocol which was happening at the time. And this is our colleagues in the UK who really were very much inspired, Professor Craig Hatton, by the work that had happened in Ireland and the outcomes for people with intellectual disability in Ireland during the COVID pandemic was very good. We had very few deaths, and this was very different to other countries, including the UK, and very different indeed to what had happened in the nursing home sector. So this was us working together. Every week we ran a webinar for the community, talking about risks, helping them to understand the data and giving them practical advice in how to work together during the pandemic. Other key developments for Wave 6 and the potential impact of our work for the Department of Children, Disability and Equality for their agenda. So DC I will refer to from here on in. But we very much looked at DC's strategies and what was priority areas for the department at the time. And we did a very intensive policy mapping exercise. We would have met with the department. We knew that areas that they were particularly interested in were workforce dynamics, employment, rates, responses, enablers and barriers, transitions, and the interplay between supports and dependence, measuring outcomes, longitudinal data, the intersections of complex needs, the barriers to healthcare and cost of services. So we mapped all the questions within our protocol that would provide data and evidence to the Department of Disability, to DC, in terms of their agenda. So that is a really important point I also want to make there. And now you can see most recently we have a very transformative national human rights strategy for people with disability, which was recently launched. And IDS-TILDA and the data from IDS-TILDA has very much informed many of the key action points within the policy, particularly when you look at areas like, just giving an example of mental health, but also in the area of oral health. And again, that is many of our members there with our Taoiseach and Minister at the launch of that critical and important strategy. And now we're very much working with the department where we will be able to monitor the actions and the goals set out in the human rights strategy going forward with the data that we are collecting. And looking at oral health, the way IDS-TILDA is organised is my colleagues, Professor Caoimhe McGillis-Fordrick and Professor Katrina Byrne, who are both managing and running the oral health arm. And what IDS-TILDA showed was that 19.3% of older adults with intellectual disability in Ireland were edentulous. That meant that they had no teeth or no dentures. And 72% who were edentulous did not have dentures. And this compares to 5.2% of edentulous population in the TILDA population. So 72% of older adults with intellectual disability in Ireland were orally disabled. And I think that was really a shocking statistic. And from the last wave, they looked at clinical measurement and noted that over 70% of people with intellectual disability didn't present functional dentation, rising to over 90% in those with severe to profound intellectual disability. So a very poor story in terms of oral health. Many people, over 90% of people not having enough teeth or the right teeth in the right place to actually chew food properly. The team and Katrina has just finished her PhD and did fantastic work in developing a modified status survey tool, the MUST tool, in order to measure and to examine oral health status for this population. And you can see a number of priority actions in the recent strategy, very much driven by the data from IDS-TILDA to address the poor oral health of this population. And again, moving further afield, the Oral Health team were honoured for work with a recent meeting in Geneva for a WHO meeting for championing the work, and this tool now has developed huge interest at the WHO level. Also, as well, Kevin and Katrina and the team have developed a number of really critical resources, practical resources, to enable people with intellectual disability to teach people how to understand, how to brush their teeth. And you can see a number of these here, which are available on YouTube, and these have been really well received. I mentioned earlier on that we started this data collection and IDS-TILDA prior to just at the start of the deinstitutionalization agenda, and we're able to look at intergenerational changes. So I'm just going to show you a slide looking at those aged 40 to 49 in wave one, and what 40 to 49 that age cohort looks like now, 15 years on. And here you can see that the resident profile has changed. We have very fewer people living in residential care, 7.7%, and this is 40 to 50-year-olds only, compared to wave 5, where we had almost 45% of people aged 40 to 50 were living in institutional congregated settings. We have many more people living independent and living now with family, so we can see the implementation of policy and the effect it's having. So when we look then at social determinants of health, we can see that things like having choice in your daily life is significantly increased between wave 1 and wave 5 for the 40 to 49-year-olds. We also seen a decrease in loneliness overall, but this decrease was largely driven by self-reported loneliness in the under 50s, falling from 51% to 34%. And it's still high, but we can see it's going in the right direction. And that's really important from a policy perspective. We also can see in terms of health conditions, we see fewer health conditions now in the 40 to 50-year-olds than we did 10, 15 years ago, with 52% now reporting no chronic health condition. We see fewer numbers reporting 3 or more chronic conditions. It has halved since wave 2. And we also see, importantly, a sharp decline in the use of psychoepileptics amongst the 40 to 49-year-olds, including antipsychotics, sedatives, etc. And this is all good news. And really, what this has shown us is that the implemented policies are having the desired positive effect. We are now seeing better physical outcomes for people who are living in less congregated, more community-based settings. We're seeing better mental health outcomes, and we're seeing greater levels of choice and self-determination and quality of life. Now, we still have some roads to go in many areas, particularly in the areas of employment, and this is a key target now set out in the most recent strategy, which has just been launched. And looking at multiple morbidity and physical health trajectories of people with intellectual disability, as I mentioned at the beginning, this is the population who are, while we have seen an increase in longevity, they're dying approximately 20 years earlier than the general population. So 72% presented with multiple morbidity, that is, 2 or more chronic health conditions. But what's really interesting here is that the patterns of disease are very different. So in people with intellectual disability, we're looking at gastrointestinal and mental health and neurological disease. In the general population with data yielded by TILDA, we're looking at the patterns are much more around cardiovascular and respiratory disease. And these patterns of disease are have remained quite stable across between wave 2 and wave 5. So many of these, of course, are amenable to intervention and to prevention and treatment. One of the areas that my colleague, Professor Eilish Burke, is very much leading out and has been on the whole area of bone health. We've seen a very high prevalence of undiagnosed osteoporosis in this population. At wave 1, over 30% had undiagnosed osteoporosis, and a very high proportion also had osteopenia. We also understand the huge issues in terms of bone health screening. A DEXA scan, which is, of course, the gold standard, can be complex and difficult for people with intellectual disability who are afraid of these environments. So the team, and led by Ailish, has been looking at innovative approaches to bone health assessment and have secured funding to look at the Echolite device. And this has a 98% concurrence with the DEXA scan, which is really good news because it is much less invasive. It can be used in an ordinary room, and it's much more feasible and acceptable to people with intellectual disability. And it includes things like a fragility score, and we have signed now an MOA with the National Council for Research at Leeds University in Leeds. And Anne Power and Stuart's Care and many of the organisations throughout Ireland now have developed a community of practice. So this innovative approach now to bone health screening is being rolled out across services in Ireland, which will really identify those who are at risk of poor bone health, of risk of fractures. And for many people with intellectual disability, should they get a fracture, rehabilitation is often very difficult for them, and adherence to the needed rehabilitation program. So many may never regain function. So fractures are not good news for this population, and of course can be a cause of death as well. In terms of medication use, this is led by our team at the School of Pharmacy and Pharmaceutical Science, Dr. Myra Dwyer and Dr. Juliet O'Connor. And here we were interested in looking at medicines. And you can see here that 21% of older adults with intellectual disability in Ireland were prescribed 10 or more medicines, hyperpolypharmacy. And this was very different to what was reported by the TILDA population, where you're looking at 2% being prescribed 10 or more medicines. And also the numbers prescribed 5 to 9 medicine as 31% was much higher than TILDA at 19%. And these were the most frequently reported therapeutic drug classes. So these were the drugs that were really driving medication use in this population. The antipsychotics, the anti-epileptics, and laxatives. And what was concerning for the medicine optimization team is, the numbers that are on one agent, but also the high numbers on 2 agents and even 3 agents, and the issue with drug-drug interactions with this. The group was also interested in looking at the sedative load, which measures really the exposure to medications which have sedative properties. And all I would just want to say about this is here that you can see that 75% of older adults with intellectual disability in Ireland were being prescribed medications which expose them to a high sedative load, and this compared to 19% in the TILDA population. So you might say, well, what do we do about this? And everything we come up with like this, our question always is, okay, what does this mean for policy? What does this mean for practice? So the team now have really very much focused on optimizing pharmacotherapeutic therapy and improving medication for people aging with ID. So we now have a bolt-on study, and it really is to develop an evidence-based tool to guide medicine optimization in older adults with intellectual disability. We have worked on the EQUIP study, working very closely with the Royal College of Physicians, with GPs, and with the groups who are involved in prescribing. And we're very pleased to receive PONS Pharmaceutical Innovation PhD scholarship now, where we have somebody really working on a proof of concept study to provide an evidence base, really to develop a tool to support clinical decision making and medicine optimization, and ultimately improve overall quality of life and health for this population. So that's just another example of how we, use the medicines data to try and move it forward to implement change. And this is frailty. This is my colleague, Professor Sean Kennelly, who is a consultant at the Tala University Hospital and also the clinical director of the recently established National Memory Clinic. And Dr. Aoife McFeely, who's a geriatrician, and Aoife did her MD with us looking at the IDS-TILDA data with respect to frailty. And really what you can see here is we are looking at, this is the IDS-TILDA, the total population, but because we want to compare with the general population, we have just looked at those over 50 years of age. And what you can really see here is that people with intellectual disability have higher mean and median frailty scores, and that these scores increase with age. And what's really concerning is that this is a population where there's a smaller proportion who are classified as robust. So you can see in the TILDA population, almost 29% were classified as robust. In the IDS-TILDA population, 16% were over 50 were classified as robust, almost half what we see for the general population. So this is an important concern. We also see that there's a higher proportion of individuals with intellectual disability classified as frail or pre-frail. And reversing frailty and preventing frailty for this population must be a key issue and a key target. And so IFA, as part of her MD, has developed an IDS-TILDA clinical frailty tool, which hopefully we will be able to roll out and use, and validated that tool, because having tools which are agnostic of disability, which can measure frailty, is a very important issue for clinical care and clinical services. So now we are working, my colleague Professor Eilish Burke is working with the National Frailty Education Programme to develop a national frailty programme for people with intellectual disability. And that's been rolled out now across the health service in Ireland, and we are very excited about that. Again, looking at how the research has influenced change across services and policy. In terms of psychological well-being and cognitive health, this was data that we looked at where we looked at the prevalence of Alzheimer's disease in people with Down syndrome and the very high risk for this population in developing dementia. And despite the known risks that we had shown, many people with intellectual disability in Ireland, and IDS-TILDA data showed that, found it difficult to access a memory service for assessment, because many people are developing dementia in their 40s or early 50s, were not eligible to access mainstream memory services until over 65 very often, but there was a huge lack of expertise amongst memory services to support and to do comprehensive assessment on this population. And while we had some very well-established services across the disability sector, there was huge inequity. It just depended. It was very much a postcode lottery in terms of what might happen. So at the time, Ireland was developing the Irish Dementia Strategy, and we were able to inform that strategy. And within the strategy, we got written into it that systems, structures, and age-appropriate services specifically to promote timely diagnosis of experiencing early onset dementia, including those with Down syndrome. So that was written into the strategy. Because once the strategy is written, the train has left the station. And as I said, if you're not in, there's likely to be little resources to follow. So then our minister then proposed the development of a model of care for dementia. And because we were in the strategy, we were also then in the model of care. And this has resulted in the permanent funding of a national memory service now, which is based at Tala University Hospital. And this means that anyone with intellectual disability in Ireland who has a memory concern can get access to memory support. And we are also in the process of developing satellite services and supporting ID services throughout the country so that people don't actually have to travel. So that is a very exciting development. And this is Mei-Lynn Yap, who I spoke about, and Mei-Lynn works with us here at the Trinity Centre for the Life Course on Ageing and people with intellectual disability. And this is what Mei-Lynn had to say. Like everybody here, I have dreams for the future, and there are things that I might want to do, and I know dementia might play a part in my life too. So when you start talking about dementia, I want to be included in that conversation. I want to be included in the conversation about my future. And I want to be empowered so that I can choose how to reduce the risk of dementia. And Mei-Lynn was just awarded, as I said, an honorary doctorate from Trinity later on last year in November. So this is my colleague, Professor Emer McGlinchey, and Marianne Fallon, who is just finishing her PhD. So we need to focus on the criticalness of brain health in terms of dementia prevention. We need to diagnose and to manage and preempt and prevent. And we know from the Lancet's Commission report that we can reduce the risk of dementia by about 45% by modifiable lifestyle factors. But we need to see how they translate and their meaning for people with intellectual disability. And I know that Emer and Marianne and others are doing a lot of work around this. But also because we had a national memory clinic set up. This is another one of our colleagues, Antoinette O'Connor, and Antoinette has been awarded a HRB Emerging Clinical Scientist Award. And as Antoinette says, we're entering a new area of AD treatment, and for the first time there are new therapies that can slow disease progression. And frustratingly, people with Down syndrome have been routinely excluded from drug trials despite the urgent clinical need for this population. So we now have established the first trial-ready cohort at the National Memory Clinic so that people can get access to therapeutics, and I think that is really important. And then we've done huge work with other services like Avista in the development of non-pharmacological approaches, helping people to live well, cognitive stimulation therapy, etc., as well as the development of post-diagnostic standards, all which translate to change care and change the system and support. We also had a focus on older women with intellectual disability, because we were concerned that they were dying much earlier than men with intellectual disability and women in the general population. So what we showed was that women with intellectual disability were significantly more likely to be multimorbid than men. They were significantly more likely to have 3 or more chronic health conditions, significantly more likely to have joint disease, arthritis, and fragility fractures and osteopenia. We also showed that they were significantly more likely to have poor mental health. Depression was significantly more common, as was anxiety. They had much higher levels of loneliness than women in the general population or than men with an intellectual disability. We were very interested in looking at menopausal health and how women experience the menopause. And we know that we noted that the mean age of menopause in women with Down syndrome was 44 years and 48 for women without Down syndrome. And this, of course, is much earlier than we see in the general population, where a mean age is around 51. 41.6% of menopausal women with an intellectual disability reported symptoms of menopause. And this compared to 90% of women in the general population. And it's not for 1 minute that I feel that women with intellectual disability didn't experience symptoms. I really feel it was much more that do with it didn't have the words to explain what was happening to them. They were less likely to be aware. Almost 50% of them were not aware of menopausal transition. And just over a third had discussed menopause with anyone. And really concerningly was that about only 16% received easy read information around the menopause, which means that over 80% of them didn't. And this is Stephanie Corrigan. She has now doing her PhD, working with one of our partners, Stewart's Care, and she is looking to investigate the effects of menopause on the mental health in women with intellectual disability, because we are really concerned in relation to the high level of psychotropic prescribing. Is it menopausal issues? Do we really understand what's happening for women? And these findings from Stephanie's PhD will inform a health education and intervention programme on menopause. And this has been very much co-developed with women with intellectual disabilities and people from Stewart's Care. But when we look at the Women's Health Action Plan, there's no mention of women with an intellectual disability in either plan. So we still have a road to go. So we're not infiltrating into policy at the level we need to be at. And then this was a report based on our health and our voices, listening sessions with women. And again, women with intellectual disability were really not included in this. And I attended a really great webinar from the HRB looking at the evidence gap and looking at women's health treatment interventions and the outcomes of a scoping review. But from this review, I think for me, the areas of concern really was that this review identified areas of huge importance for women in the general population. However, many of these conditions were not really relevant for women with an intellectual disability who are typically nulliparous. Many of them do not have children, particularly this generation. Hopefully that will change with future generations. And the priority areas identified from this review were around female fertility, postpartum mental health, and early pregnancy loss. And these are really important for women. But for women with intellectual disabilities, there are much different issues that we need to look at. So we need to focus on outcomes and conditions that are specific to women with intellectual disability. We also had a focus on the social determinants of health and choice in interpersonal relationships. And this is Dr. Andrew Allman, did his PhD, and Andrew is now working at the National Disability Authority. And he looked at loneliness. And we can see here that loneliness was quite prevalent in people with intellectual disability, and women particularly experienced high levels of loneliness. And you can see the spike in loneliness during COVID, and I think that probably was relevant to everyone in our society during that terrible time. But loneliness and its loss was some of the most bitter and the hardest forms of loneliness for people with intellectual disability included the loss of family members, the loss of staff, and the loss of friends. And participants were very often unable to adjust to the new context after loss because they had no replacement relationships. And it was often concealed during the day, but hardest at night. And just read one quote here. Mostly at night when I'm sitting here, and there'd be times I'd love to have someone who to kind of say, oh, that was very funny on the television, or that was lovely, you could see that view out, it's gorgeous. And I just can't imagine what it must be like for somebody not to have someone to share everyday life events with, joys, sadness, etc. So from that data, then we were lucky to get a HRB funded knowledge translational project, and we worked with Stewart's Care in Palmerstown, led by Dr. Darren McCausland. Darren did his PhD with us, but is a joint appointment now. He's head of service innovation at Stewart's Care and also an appointment here at the Trinity Centre. And that work very much focused on building circles of support for people with intellectual disability. How you actually build these circles of support to prevent issues such as persistent loneliness that we so often see in this population. And that's on YouTube and has been extensively viewed, and people can see. And again, it's an example of how we took the research, how we implemented it into services to change how we were delivering care and support. So at a global level then, in terms of the global policy level, I think IDS-TILDA has had about 102 policy citations across 17 countries, with 37 policy citations from the US. So not only is it impacting a policy in this country, but we can see the impact of this at a policy level, at a global level. So in Ireland here, our Minister for Older People set up a Commission on Care post-COVID. And this really was very much to look at determine the effectiveness and adequacy and efficiency of care and support, which are currently being provided within the health and social care system, and plans for the future development in meeting evolving care needs of an increasingly diverse older population in the context of ageing. And there's 12 people on this commission, and it's being chaired by Professor Alan Barrett from the SRI. And I was very pleased to be appointed by the Minister to that commission. Obviously, ensuring we have good service for everybody, ensuring the needs and the unique needs of people with intellectual disability are represented in any future plans. And we were able to get the Commission to facilitate a focus group specifically with the disability sector to hear firsthand the concerns around health and social care support for this population. So hopefully in the recommendations from the Commission, this will be reflected, and that is really important. We also focused on developing strategic partnerships to influence change and to create really pathways for communication. So we have setting up the centre here, the Life Course Centre on Ageing and People with Intellectual Disability at Trinity, developing a very comprehensive strategy was a really important landmark for us here to be established as a recognised centre within the university. Within the centre, most recently, we've established a policy lab, and this ensures that the evidence and lived experience drives policy change so that people with disabilities and their families are central to decision. And this is really where research meets action, and my colleague, Professor Martin McMahon, now will lead the development and the rollout of that lab. And we're signing and working with the policy lab at Sydney University. I've just been over at Sydney, who are very interested in partnering with us in terms of what we are doing here in Ireland. We have also set up a research to policy steering committee with the department. And this is a more recent development as well. And we're very excited about this, working together in partnership, identifying and addressing policy and relevant research and data needs of DC and other departments, and addressing what the policy needs of our colleagues are within the various departments. So this is really exciting, and we're very pleased with this. We have also set up priority setting partnerships. We have a long-term partnership with the National Federation of Voluntary Service Providers, which is the umbrella agencies which provides supports to members who provide care to people with intellectual disability. We have also great partnerships with people like Down Syndrome Ireland and the HSE and the director of our national clinical programme, particularly Dr. Rosemary McCarron, who's there currently. And we strategically hold a number of ideas events. And this was one recent one as an example here, translating IDS-TILDA knowledge into policy and practice. And this was held last October. And we had hundreds of people attend this, but we had, people in the room from every sector, those who are commissioning service, delivering service, using services, and then the academics, helping them to understand the relevance of this data for policy and change. We held a recent event here in the Trinity Business School. One of the big issues is how we're going to support an ageing population, and we call this broken systems, too little money. And here we brought all the stakeholders into a room, and this really widens the discussion, and it's really where the magic happens and really promotes this systemic thinking. So we had our department colleagues, the NGOs, the deliveries of service, our regulators, everybody in the one space trying to understand and think together how we're going to work to meet the needs of this population. It's really important as well, we felt, to establish strategic partnerships to influence change. So we have a number of joint appointments and joint PhD programs. So as I mentioned earlier, Dr. Darragh McCausland, he's Head of Service, Innovation and Development at Stewart's Care. So we don't want to be putting PhDs through with the idea that everyone is going to work in a university. Yes, we need people working in universities, but we need people working at the policy level, at the service level, at the front line. And we have a very big focus on this. Stephanie Corrigan, who I mentioned, who's doing the women's PhD at Stewart's Care, and then Riley Burke, we've set up equine therapy and understanding the relevance and the usefulness of equine therapy for people with intellectual disability. And most recently, we have been going through the process of the appointment of Associate Professor in Translation, Innovation and Evidence-Based Care between Trinity College, between our centre and Stewart's Care. And that offer has been made, and it is just at appointment stage. So these are some of the ways that we have been trying to work. This is also my colleague, Professor Eilish Burke, and she has developed a MOOC, really very much focused on empowering health care and those delivering healthcare to understand the healthcare needs, but also to develop professional capability, how to make reasonable adjustments to have a good consultation with somebody with an intellectual disability should they attend a health clinic, a hospital, or wherever else they may need support from. So just to kind of draw it all together, one of the first things that we felt we needed to do at the beginning was to build a human infrastructure. We needed to get people interested in the ageing of people with intellectual disability. We have put through about 30 PhDs, MDs from every professional background. So these are the next generation of thought leaders, and this will improve care. From the very beginning, we focused on developing a community, a PPI network, a living partnership, and that has been ongoing with people with intellectual disability. I spoke about the policy infrastructure, the policy lab, and we're very focused on that. I spoke about building the clinical infrastructure and the care pathways and reimagining those and translating that. So the work at the memory clinic, as well as the bone health and the community of practice, are all examples of this. And then systems change, like building the physical infrastructure here and the centre at Trinity. And of course, having really good evidence and really good data, building the infrastructure. And IDS-TILDA, I think, has really been successful in doing that. And we have a huge data legacy. And I think Ireland can be rightfully proud of its role in terms of creating that data legacy on the ageing of people with intellectual disability. So I think, IDS-TILDA is more than a study. It's very much a movement towards inclusion, towards evidence, towards equity. And it does reflect what's possible when lived experience drives research, and what's possible when you have trusted data and meaningful relationships and relationships with a wide range of stakeholders. And the future is life course, person-centered and rights-based. So just to conclude, I think my concluding thoughts is, and from my experiences, you really need to understand the policy life cycle, the policy mapping, which we engage in on a regular basis. Research needs to be relevant. It needs to be relevant to policymakers, but it needs to be relevant to services. It needs to be relevant to people with ID, to people who are experiencing so many of these issues. You need to understand the context in which policymakers work. It needs to be feasible. It needs to be implementable and manageable. So there's no point in us coming up with grand ideas that are simply out of reach and it's just going to be too difficult at multiple levels to implement. You need to become a trusted party by the quality of research you're doing. And of course, we're academics. We need to publish. And you need to look at creating a formal and informal pathways for communication and build relationships with diverse groups. That is the most effective way. And hopefully you'll have got a glimmer of the diverse groups that we have built relationships with over time. And you need to share the evidence in multiple ways. Yes, as I said, peer reviews, but you need to attend events. You need to walk the room. So oftentimes you come into a room, but we don't go in with a purpose. So you need to go in, you need to meet people. People are busy, but people really do like to hear from people. Create these opportunities for systemic thinking, bringing people into a room. So we do that through the policy lab, the series of ideas events that we run all the time. There is a lot of expectations on us as researchers to engage in the policy process and debates. And I also want to highlight the really good resources that there is available on the HRB podcast series. So thank you, and I hope that was useful.
Thank you very much, Professor Mary McCarron. That was incredible. It's amazing the amount of work, research, and the impact that the work that you and your team have had, not only in Ireland, but as you said, globally. So I think you mentioned very important advice for people who want to impact policy. You mentioned the importance of trusted data, of PPI, engaging with the people who are going to be affected by the research, and knowing as well that systematic thinking of the system and the groups they need to engage, and knowing the policy life cycle. And you mentioned as well in terms of the policy window and what happens when the train leaves the station. I was wondering if the train has left the station for someone who is listening, is there anything they can do? Is there anything that they're still, maybe that they can?
Well, if the train has left the station and they're not in, one thing they probably could do is exactly do the policy mapping exercise, become the person who's able to evaluate whether the target set out in government policy is actually being reached. and whether those targets are actually making a difference to the lives of people that they are interested in following. So like the cancer strategy is a good example where we can see great progress has been made. It's a completely different area to mine, but we can see that strategy, really good targets, and we're able to measure those, and researchers in that field will be able to look at that. So that's one way, is measuring the targets set out in the government policy, even if you haven't shaped what's in them.
Thank you. I see there's some questions coming through. I'm just going to give as well people, if you want to start typing your questions, there's a question probably more at a micro level, more of the individual. I think someone that says regarding the wider population, if you're not involved with IDS-TILDA or you're not part of the IDS-TILDA family research, and you have a person with a family member with intellectual disability who has no support program, how can they maybe access services? They were accessing service before COVID, and then those services no longer exist. Is there any resource that you would recommend that they could access, or any place they could visit to try to get into the system?
Yeah, well, I'm not exactly sure if that comes from a family member or somebody with intellectual disability themselves. And I may not be able to answer directly where they are, but they need to link with their local area and who their local service provider is within the system. So there is, there is a regional system now, and I think that may be impossible. That may be possible for them to do that. And I'm certainly happy to link in with somebody afterwards if that's helpful to them.
Thank you very much. Just another person asking about the presentation and if it will be shared. We're recording, so the recording will be shared. It'll be available on the website, on our website, and it will be shared with everybody who has registered as well. So you'll have access to the recording. Just another question. I was thinking you mentioned as well of the importance of not only of the research you're doing now, but the succession planning and the sustainability of the research you're doing. I thought that was very interesting, that kind of it really shows kind of a leadership approach to research, and maybe how important you think that is as well when you're looking at impact in the long term.
Well, I think that is key. And from the very beginning, I mean, I think I'll judge my own success on how well all of this continues. And that is so important. So very often, of course, we don't build that infrastructure. So we've been very focused on, you've seen there how, different people from different schools, from different professionals are now leading the various arms. I think that is key. We must build sustainable leadership so that this all can continue. So creating opportunities for more junior academics to lead, for somebody like me to step back to be much more in a mentorship position so that they can take on those leadership roles so that they are prepared to continue, because that is really important. We owe it to the disability community that continues. So I feel there's a huge responsibility, as well as a professional responsibility. There's an ethical responsibility as well to ensure we have left the place in good stead, and that we have looked at succession planning and how all of that can continue. So that is a huge major focus of my work, is in building the next generation of thought leaders.
Yeah, I think that was very clear when you showed that all the different people working in your team and all the different areas they're covering. And of course, impact takes time. So that's so important, that succession planning that you do.
Yeah.
In terms as well, you mentioned of the importance of adapting the message to each of the different target audience of the people you want to reach with your research. So you talk about research translation and different outputs, like you had the MOOC, there was guidelines and different type of outputs as well. Maybe how important is that research translation to get to the different groups? Do you think it's essential in adapting?
Really important, because what a policy maker wants is very different to an academic paper. They haven't the time to read it, it's probably too complex, so they need very key snippets in a timely manner. So policy brief is very different. So we need to become much more apt in the academic community in understanding even how to put policy briefs together and working with people. Then if you're working with, service providers, people themselves with intellectual disability who need to understand issues around their health and how to prevent ill health and how to promote well-being, you need to present it in a way that they can understand. And that's why we work so much with people with intellectual disabilities. So they are the ones, Mylene Yap, the lady with Down syndrome, she's the lady that actually has, presented the data and presented in very much an accessible manner to people with intellectual disability. So it is really important to know your audience, who you're trying to get this information across to, and to realise for most people, they probably have only a couple of minutes.
Thank you very much, Professor Mary McCarron. So a lot of people are thanking you for the webinar and the information. And I think if there's no more questions, we're going to close it here. Thank you to everybody as well, for all the participants, to Professor Mary McCarron and to Elizabeth for the technical support behind the scenes. And don't forget our next seminar with Professor Joseph Roche. So that's on the 5th of February. Thank you very much and have a lovely afternoon. Thank you, Professor McCarron, again.
Thank you very much, and thanks to everyone for attending. Thank you.
Thank you.